Uh, Dear Facebook Pure viewers, uh, good evening, everybody. Like everyday talk, we are today focused on the surgical technique of micro ECIRS. That is, during PCL, you will have a small tract. And before Dr. Vineet Gauhar told me about this talk, I also did not know what is micro ECIRS, to be honest. I was thinking that micro means the tract will be small. So let us listen from him. Before going and hand over to the Vineet Gauhar, I wanted to ask you. Hi, good evening, Vineet.
Hi, good evening, Chandra, and good evening to
Yeah.
everybody.
So I remember you did your MCH from SRMC Chennai.
Yes, I did. Yeah.
After that, you got interest in robotic. You wanted to work abroad, and then you moved to US, if I remember correctly, for fellowship with somebody I don't know. Please let us know after your MCH what happened, and briefly who made you to think so broad-mindedly. Going, are you same personality when you were in MBBS, or you are different now? How the evolution occurs when you go abroad, work with different people? Does it made any change in you? Because now we see you as for example, the way you discusses the things in the social media related to academics, the way you take your the negative things also when somebody comments, the way you project yourself for the imagining about the future, the way you are writing the papers, all this won't happen in one day, especially those who are brought up and made their career MS and MCH in India. It is not easy. Those who have gone after MBBS to US and UK, they get adopted. But after MCH, going out and mingling with the world well-known people easily and getting along is your nature. Can you brief it?
So, thanks, Chandra. I don't think so much about so many things, but I would just say that when I finished I've always been one to adopt and to accept whatever change comes. And I started off with wanting to be a transplant surgeon, and I was very grateful when Dr. Shroff gave me the opportunity to work with him. In fact, I loved it so much. And then I almost moved to pediatric urology thanks to Dr. Ramesh Babu. And I was set to do that. In my very first case in my career was actually a pediatric case. But somewhere I was a bit frustrated because I couldn't do a good PCNL since we didn't have much in our hospital. And as good as I was in the other subjects, I thought, okay, let me go and try to get some experience. So I had a chance to present in the US, in Cleveland, and I went there. Dr. Gill was very nice to take me under his wing. Andy Novick gave me an opportunity, and they initiated me into laparoscopy. So,
How you get the opportunity? mm, Uh, um,
well, I think you just have
to
to
Andy Novik,
make.
because at that time they were the legends. Even to go to them and join, what is, was it fellowship or did you do your USMLE?
No, I didn't do any of those. I was one of the luckier people for them to kind of, I must say, like. And it was a very small stint over there, but that's what changed my whole perception to the rest of the world.
Yes,
And then I decided, let me train myself in laparoscopy. So I went to Strasbourg in France.
yes.
And that's when I got introduced to many people over there who changed my whole perception about urology itself. You know,
Yes.
I think moving outside gives you the exposure, and being probably a trained specialist, you sort of recognize the opportunities more than
Yeah.
when you are a medical student. So from then on, I think that it was just looking at opportunities, finding them, taking them. Singapore was a good break because
Are you married, if you don't mind, before you go, you went to moving out of the country?
yes, of course I am. I have a son,
So
and
all the journey you did, was it a little difficult in the initial part to go move around, learn? I mean,
yes,
definitely it is working more hours now. Initially, as a junior, you have to prove interest to the seniors.
no,
Is
yeah,
it
of
so
course you have
difficult
to.
after 25, 30 to do that?
Well, when you go outside, one thing you have to know is that you are not recognized for just your degree. You are recognized only for your work. So people
Yes,
over there need time to know whether you are capable or not capable. They
yes,
respect the fact that you have trained. They give you the respect when you have trained fully.
yeah,
But then you earn the gratitude only by working over there. So Singapore took time. It took me a good 7 or 8 years
When you
to
moved from, for example, you did your MCH from which year you finished?
a long time. So I think it was 2005, I think, or 5 or 6. I can't remember.
So
Around then.
same batch. I finished my MCH in 2006 from Chandigarh. When did you first post in Singapore?
I came to Singapore only in 2009. So it
2009.
was,
So
I
in
was an
this,
assistant professor and working in Ramchandra. I was also going to put up my own center like you, hopefully. I was planning to put up something like that.
okay,
And
where?
then,
Where?
well, in Chennai, I was looking to put up, in fact, that time there was no dedicated urology center except RG Stone.
Okay,
I was hopeful to put up something on that line, but as life would have it, it had other plans for me.
very
But
nice.
academics has always been my, and education has always been a passion. So that's the only thing which drives me. So I think as long as you have that drive that you want to learn, I'm sure everybody is going to teach you. Nobody will tell you no when you want to learn. Everybody is more than happy to put their best foot forward.
Given choice, one surgery if I have to give you, which
Yes,
one you choose and want to practice? For example, God asks you to practice only one surgery for life. In urology is a super specialty. Which one you
I
will take?
I love anything to do with endourology.
In
So you
endo.
give me you yeah, and as much as I like endourology, I'm not a big fan of bladder cancer. So the advanced bladder cancer work, I respect the people who do it because I think they're fantastic. But even I have trained, I mean, I have had the experience to work with even Professor Studer, but I'm not inclined to that. But if you ask me one surgery, I think anything to do with endourology and robotics. These are
Robert.
the two passion things for me. Yeah.
And the last question before I hand over. Now the people are joining because they always join within 5 minutes before they miss the talk. I wanted to continue this for 2 3 more minutes. Around 35 people have joined. Let them become 50 60. Then we will move on. Usually this talk is made with a YouTube link and which will be there forever. So today evening they will be seeing around 300 to by tomorrow morning it will become 550 and then 800 like that. So entire talk now what we are doing is also recorded. It encourages the juniors what the path they will choose. It's not easy when I came out to Hyderabad and had little bit of hard work. The only thing is that I have never given a chance to go out due to various reasons. Now, second important part I want to ask is why we are doing so much work in India. Sometimes it is not possible to convert into the paper, scientific paper. What exact? Even though it is irrelevant question, but relevant because this is a forum mainly kept in for the junior urologists who come out. I had a huge dream of joining institute government and do some paperwork. I had around 15 papers. Then 16th paper it took again in private practice 5 years for me to do that. Why?
I think
What is the exact reason? Are we
I
not trained or lack of attitude?
no. I don't think there's anything to do with training, and I don't think there's anything to do with lack of attitude. But I think it's the environment that you are training in, which has to nurture you to present and make papers. For example, when we were training, we were constantly being told, publish something, and you won't believe it. In my MCH time, I did two I did one full thesis and another one a whole research PhD, literally on tuberculosis of kidneys, etc. But I couldn't get to publish them because I was not motivated enough. I was just keen to learn. So it would probably be your professors who guide you that you must do it. We presented a lot, but I think currently the scenario in India, I'm pleasantly surprised when I see so many publications coming from Indian colleagues
Yeah, now
and
it is very.
urologists. So I think today the necessity to publish is there. The environment to publish is supported even by the Urology Society of India, by your own colleagues, by your own professors. Everybody realizes the merit of publishing. It's not about recognition. I think it is about giving the information to the world that there is all these possibilities and these are the things that we are doing. We have the volume in India. I don't think you can beat the volume that we get to do in India and maybe China. So when we have so much of volume, you need to have a mindset to publish. That means you're learning. You need to make sure that you get that data, organize that data, and publish it on time. Our problem is we get too busy and we say, let's do it tomorrow. And then that never happens.
Yeah.
And by that time, in the world today, there is somebody else who's published, and the publications are so many people will obviously not give you the full due. So you have to be ahead of the rest of the pack. So
The
for that,
amount of
you
the
need to work hard.
work we do, we don't spend enough time. I feel there is something related to attitude
I
also. Let's hope a team works will make the you are doing a little bit of teamwork. Sometimes somebody is busy, some collect the data, some give to him, some writes.
Yeah, yeah.
That's a good idea. That's a very good idea. With this introduction, we reached around 50 now. So we will move on to our topic. I will officially introduce you. A lot of people know you now. You are one of the very known Indian to the Indian society because you are active in the social groups and actively involved in the discussion. And most important thing recently I have seen is whenever you listen anything, you make summary and put it. Oh, if somebody misses, that summary helps a lot. That's really good character. Video based circles discussion today we are doing on ECIRS process and pitfalls. Dr. Vineet Gauhar, I came to know 2 3 years back. Suddenly I met in I think Barcelona first time in the on the ground floor in the conference, SIU conference. After that we became friends, and I came to know in depth about him. Quite an active and broad-minded guy. Principal resident physician urology, Teng Fong General Hospital, clinical lecturer NUS School of Medicine, physician faculty residency program NUHS, fellowship program chair. His field of expertise is minimally invasive surgery in calculus disease, renal cancer, and kidney diseases. Well acclaimed regionally and internationally for training of national and international residents and fellows. His department is a premier tertiary institute for MIS in stone and prostate surgery. His areas of focus also include mere urethral disease and urethral reconstructive surgery, which is an area of expertise extending to substitution uretroplasty. With a key focus on teaching, clinical research, and minimally invasive surgery, and have received thrice the Service Quality Award and Long Term Service Award in Urology and the Silver Service Award in Urology. That's great. I didn't know this. Really appreciated. He is actively involved in organizing and chairing numerous clinical meetings and training forums of residents. In fact, Urological Society of India, a lot of the seniors recognize him every time he participate in the debate or in chairing the sessions. In that way, helping a lot of the Indians and getting motivated. After he left India also, he is with us constantly, almost like any other Indian urologist. So with this introduction, I will hand over the program to Vineet Gauhar sir. Thank you very much for the accepting the invitation, and love to listen from you.
Thank you, Chandra. I wanted to congratulate you for that tremendous effort of not only being a private practitioner, setting up so many branches, and then your 4,000 plus people have joined Pure Urology, which is amazing in such a short period of time. It's a privilege to be here. I'd like to say to all the viewers, bear with me for maybe 25, 30 minutes. I'll try to speed up where I can. I had to put together some of my slides. We have a second wave of COVID again, and it's been a bit busy here. So with that, let me start screening. If you can see, are you able to see my screen?
Yeah. Uh, uh, you are able to share or no?
I just did, but it's not sharing, is it? Let me try again.
I made already co-host. Yeah, it's coming now.
It's coming up? Okay.
That's fantastic.
Okay, great. So the topic I was allocated is micro, actually micro perk, and what I am going to be talking about is actually a micro ECRS. But
Yes.
there's and the process of doing micro ECRS and the pitfalls that it sort of overcomes of micro perk. I think we are today, right now, the management of renal calculi is really, it's going through three phases of evolution, kind of a revolution and re-evolution. We've evolved in these ages of mankind from ESWL to MIS to artificial intelligence. So we've all come to a point where we know PCNL can be done in prone. We've accepted that it can be done in supine. We are doing all these fancy surgeries. So we are definitely, I would say in the era of advanced endourology. I actually call it endoluminal endourology. It's a term coined by Darren Smith, who's the head of BOSS. We actually have, both of us believe that the term should rightfully be called endoluminal endourology, so bear with us. Now, where am I over here? I'm talking about how micro became sort of mini micro, and then ECRS, we blend these together in our galaxy of PCNL. Now, we are here today to discuss not the fact that prone to supine change, that change has already happened. Evolution of ECRS, I think that also has happened. Miniaturized ECRS, I think that also you know, and you've sort of come to accept, yes, it's happening. But we are here to discuss more on microperk and ECRS. I'll share a little bit of my experience on this and then how we go forward. And why we want to go and where we want to go eventually is the concept of tailored stone management. So I think this revolution in PCNL is in all these aspects of PCNL. But the most significant adoption of a change has happened in the tract size, rightfully. It has happened in patient position, which is prone to supine. And then, of course, we are all working towards making the stone surgery cost effectively a single stage stone free rate. That's ultimately the aim of any surgery. And you cannot go to something in the future unless you take a step back into the past. And if you look back, this paper, I think almost everybody would have seen, which was put up by Professor Traxia. They always tell you this picture and they show this and they tell you, oh, this is what happens. But they also actually tell you in the conclusion that there is no consequence of dilatation whether you do a 30 French or a 24 French. It is just a scar. But what they don't tell you is if you put an instrument into this scar, rotate it and torque it in a live kidney, that kidney is going to bleed. And the factors associated with hemorrhage we know are, apart from all that, an increasing tract size. That is one single thing which almost everybody agrees.
Yeah.
If it's not, by chance, there is a problem with accessing the tract, if you dilate that tract, it will bleed for sure.
Yes.
And then that's the Achilles heel to PCNL. So with that, the main concept was let's decrease the tract size and let's miniaturize the tract size. And that has led to the evolution of PCNL. And where we stand is not where prone I think is out and supine is there, but a lot of people do prone. I don't think there's anything wrong. I won't debate that. That's for another day. But I'm just going to focus on this evolution period of 2008 to 2011, where we had a concept of micro PCNL come in. We had acceptance of supine PCNL and the various positions, and then the concept of endoscopic combined intrarenal surgery. And I'll put all this together when we go ahead in the discussion. I have to say that if this discussion would never happen had we not had Professor Mahesh Desai in 2011 do the first microperk at all. And he said it's technically feasible, it's safe, and it's ideal for small volume renal calculus disease. Now, that was the patient population in pediatric age, who he also did it in all the funny kidneys because he's got an amazing amount of experience. But can that be replicated in the real world? Let's see. Fortunately, we also had another professor, Professor Janak Desai, who came in with a concept of saying miniaturized PCNL is there. And he did some tremendously fantastic work to show you that ultra mini PCNL is really good. And this was a time when flexible ureteroscopy was actually trying to gain its maximum momentum. And he said, if you have an instrument like this, just do a simple PCNL and you can get away with it. But these are all closed systems. They don't allow the stone to be removed. They don't. I mean, you can remove a bit of stone here, but they don't allow the system to be flowing through where the pressures are low. So people were very scared. Should we adopt them or not? In the micro PCNL, Professor Sabnis, he took it one step further and he said, I will invent what is called as a micro mini concept, where you can make that micro, which is 4.8, into an 8 French. And you can actually get away with a lot of things with that 8 French. We'll come to a little more detail on this later, but this is how the evolution happened. Now, why would an evolution happen if something was not useful? I think obviously they were the earlier people to see the benefit of this in future, and that's how things have evolved. And fortunately, there was a very nice article that came out from Professor Desai again, who very simply put, he said the limitation of ESWL is its unpredictable results. True. The limitation of RIRS is, yes, it's highly sustainable, but cost and poor durability. And we all know you don't handle the RIRS flexible scope well, it will break. And the problem with PCNL is its invasiveness and associated morbidity. So his working hypothesis, which he proposed in 2012, was that the all-seeing needle, and that's very important because it's an all-seeing needle. I'll again introduce you to how each part of it is important, is that it gives you a very, very perfect initial tract, and the tract morbidity could be immediately reduced. And I think that is the critical part of PCNL. If you can reduce the morbidity of a tract, Everything else, your experience will help you to clear. I'm not here today in this forum to tell you that this is the best way forward. I'm only telling you how things are moving forward and how we are trying to move forward. So, what were the limitations, what we call as the pitfalls? We couldn't use this in big stones, so size of stones was a criteria. We were worried about intrarenal pressure, and intrarenal pressure, rightfully so. If you have a closed system, irrigation going in, nothing coming out, kidney is going to stretch, you're going to develop sepsis. And a big problem, you can't remove the fragments. How do I take out the fragments if I leave this behind the stone filtrate? But if you look very closely at literature, these limitations were only between 2013 and 2016. And there's a certain reason why it was between that time, because microperk was not used beyond children. And they were the people who were using it and saying that in children also we feel this is the maximum limitation and you shouldn't be doing more than that. There was hardly any paper to talk about in adults. Now, what can be done to overcome this? Again, from the team of Nariad, Professor Kanpule Arvind, he came out with this and he came out with this nice little review of literature, which said it is actually, if you look at all the papers which are presented, MicroPerk alone, the rates are comparable with RIRS. It's a very safe access. It's associated with a high success rate of surgery, very short hospital stay, hardly any problem of bleeding, and hardly even lesser complications of at the if you take grade to grade for Clavian grade. So this actually allowed a certain incentive to be given for accepting that what we have been talking about miniaturized PCNL is definitely the way forward, and there's a role for everything. At the same time, there was what I call as the rise of the RIS, including myself, where everybody started doing RIRS because it was something what did we want? We want a shorter hospital stay, we want improved outcome, we want minimally invasible, and we want it to be replicable. And that's why we started understanding that RIRS can be done and much better understanding of anatomy of the kidney, lasering techniques, improvement in scopes, training and training models. But all
I
this
just
was
stop.
happening.
I just stop here one second.
Yeah.
Sorry for interrupting. I am also one person who moved from PCNL to the RIRS, and too much I moved to RIRS, and I am known for RIRS. You now you do supine PCNL. You have done prone. You have moved to RIRS before you continue this talk. I
Yeah.
say that for less than 1.5 centimeter stones, if freedom is given to you, you are the boss and nobody and patient is whatever you feel you do it. You have all armamentarium. Will you choose mini perk or RIRS? Less than 1.5 centimeter. This is unofficial question, no studies, no statistics. In your mind, irrespective of the stone density, but
So
located in the pelvis and easily accessible area.
So I think the answers lie in all that you told me. It's a small stone. It's in a good location. It is in a favorable anatomy, and the patient definitely wants a minimally invasive surgery. My first attempt is always RIRS,
Yeah,
up
please.
to 2 centimeters. It's
Yeah,
always RIRS.
please. Okay.
But the only problem, as you know, in RIRS is whether we will go up that ureter. Nobody knows
Yes.
until you actually start to go up.
Yes.
Yeah.
Yes. Correct. Thank you.
So I think when we came to RIR, we have accepted that RIRS and people started using it. And endourology is very easy. We are so used to ureteroscopy, so it was very easy for thousands of people to adopt it, thanks to
Yes.
Professor Traxia and all the studies. And it was time for change.
Yes.
So if you're going to change, and we have accepted that miniaturized PCNL is here to stay, RIRS is here to stay, supine is here to stay. Why not we combine all these three things together? So the best way is, shall we do an endoscopic combined procedure? And that's what ECRS is all about. Can you imagine a professor who's been trying to tell the world this from 2004 actually was not able to make his first impact until 2011? It took Professor Scofone 7 years to tell the world that ECRS is something that you can do. And the reason being that most of the people did not move from prone to supine. Most of the people did not move from traditional PCNL to miniaturized PCNL. So with advancement, everything changes, is what we're trying to say. And the minute he brought this out into the world, people started thinking that's fantastic. The biggest advantage of this was any stone, anywhere, any anatomy you can do it in. But again, people have something to criticize. So they said, oh, it's costly, it's two surgeons, and it's a very disorderly OT. This book is something which I definitely advise all of you to please read, whoever wants to do ACRS or whoever wants to understand supine BCNL better. It gives you a very in-depth knowledge of how things can improve in your own practice. Now you tell me, if I give you a picture like this, does this look like a very disorderly OT for two surgeons to sit down? And this is a very, very small room. This is anybody's OT in anybody practice in anywhere in the world.
Yeah,
I don't think this is a disorderly OT. I think it's very easy. He has defined it very clearly how things should be placed, how monitors should be placed. Cost is an issue when you have to spend for a lot of things. But remember, ultimately, if you can have those facilities, why not let the patient benefit from the cost of going home faster and let that cost benefit go to the patient?
yes,
You will realize that your own goodwill will go outside and say, "Oh, I went to Chandra's hospital, I went to XYZ hospital, and they really sent me home the next day and without any complication." And a patient will bring a patient. Ultimately, it is only a patient who speaks for your work. And
100%.
that actually, I feel, is where ECRS really holds its true value. To be able to render the patient stone free in a single day, in a single setting, and send him home so that he carries the goodwill out.
Yeah,
And this is how practically they're doing it over there. You see so many people are there inside the OT in that same space in a different camera angle. And all the trolleys, everything, there's a lot of place, there's no problem. The OT setup can also be modified to do something like this, where you have two monitors on one trolley or one monitor and all the systems on this trolley. These are very customizable trolleys, they can be made anywhere. So I think this is something which you please change your mind that OT space is a problem. I don't think OT space is a problem for sure.
yes,
Now, ECRS is a very simple concept. It's a synergistic approach. What do we do over here? We put a scope up, which is basically RIRS. We put a scope through. So if I'm going to do a scope from here and a scope from here, why not I use the smallest of instruments which are available to me to clear the biggest of stones? And your question will be, how am I supposed to clear a big stone just because I have two small instruments? When two small instruments are inside that space, they give you much more opportunity to work independently. And that's where I keep trying to tell people ECRS is not too big to put two instruments inside and say, I don't have space. You do first, I'll do first. No. ECRS, if you want to work in a big stone, you work together. And for that, the best way is have two small instruments. I will work in a different part of the kidney. You will work in a different part of the kidney. We both will then meet somewhere. At least our instruments won't clash. That kidney space with a very small instrument will allow me to work. And this is how I work. I go here, you stay on the lower pole, I go to the upper pole, or vice versa. That way, I also save a puncture. I also don't interfere with you. I don't have a chance of damaging the instrument. But when I say small, I really want to go small. So for that, I really must know how do I do it. Everything comes with learning. And these are the three simple principles you want to follow. Either you do synchronously, that means I'm working here and he's working here, or I do simultaneously, where there are instruments which are working in all different poles, which are all flexible, or synergistically, the same stone you and me break and we keep passing. So two surgeons are working together at the same time in different ways. And these three S's are the key principles to learn for ECRS.
yeah,
What happened with this understanding and acceptance is suddenly people realized, I think we can do it much better with ECRS.
yes,
And this gives you a very versatile and a personalized concept and a tailoring approach. The restriction of mini PCNL, of all these smaller PCNLs versus 1.5 centimeter stone, suddenly may not be a restriction when you have opportunity of two surgeons working with two instruments inside the kidney at the same time. And that's what truly happened. And that really actually allowed even more complex cases like diverticulums, transplants, pediatric cases, and even patients who have had partial nephrectomies to go through surgeries without morbidity. It's not about doing surgery. It's not about whether I do it. I'm sure you can do it. Whether you can do it without morbidity, I think when you have a miniaturized PCNL, the morbidity definitely comes down. And it's an overall morbidity. Very often the question they ask is, in my hands, I don't see so much bleeding. Good. When you finally ask that person, they tell you, I have 2000 cases experience. How many people in the world have 2000 cases experience? Not many. So I want a surgery which everybody should be able to do safely, not just because you have the experience.
yes, yes,
So I say that this is a very good guideline which tells you ECRS can actually be done in all the settings. And the good part of it is you can combine it with ultra mini, standard, whatever you want. So you can tailor it depending upon the stone and the instruments that are available to you. But the point is, ECRS is a factor which is available everywhere. And that's why I think they came out with this wonderful review, which finally said, look, ECRS is better than PCNL. You can avoid the need for multiple access. Your stone-free rate is good. Your operative time is good. On all accounts, it's a winner. So when we have established that ECRS is here to stay, we have established that mini ECRS or miniaturized PCNL is here to stay. My thought process was, can we have the procedure which can have the smallest puncture, easily doable, reproducible, minimal complications, and 100% stone-free rate. Cost effective to me is when a patient can go home with minimal complications and lesser hospital bill. Cost effective, I know, is a big debate when it comes to I have to spend out of my pocket for instruments.
Yeah.
So I think today, yes, we can. And why we can? Because we all know that we have had a real revolution of various, methodologies as well as equipment which is available today. So you decide in your setup what will be your best instrument setup that you want. You cannot buy everything, so choose the correct one. For that, you need to have education, or you need to at least understand which is a good option. But you need to adapt to times. Now I'm here again to just talk about micro, right? So to me, I made the change in 2013 to prone. I went to 2016 to ECRS. I miniaturized my procedure of ECRS to 2018. And then I started concentrating on the concept of micro ECRS. And today I'm focusing on the concept of tailored ECRS. And this was a talk, I was very happy to see this in one of the talks which happened in USI, where Dr. Tai from INU, he said the best of all three modalities is when you do a miniaturized ECRS. I think that just summarizes the whole thing. So when we are here, what exactly do we do next? We've conquered mini PCNL, we've conquered supine PCNL, we've conquered ECRS. So I think the only thing left to do is let's look at micro ECRS.
Yes.
But you must understand, friends, that if you want to do micro ECRS, you must know how to do RIRS for bigger stones, and PCNL, the track size will get smaller. You must know how to do a small track PCNL. This learning curve is where all the challenges come. And you need two surgeons to be working together. So you have to understand this is my job and that is his job. So this is something which Chanda and me were discussing before. So that's how I evolved. It took me also time. I had a lot of mentors to help me out. You need your mentors to guide you through. And as we evolved, I wanted to just thank Dr. Santosh, because he introduced me to the concept of doing a mini PCNL. And then when I met Dr. Janak Desai, he just changed my whole world when he said, "Oh, I think you should really go miniaturized, even smaller."
Yeah.
So from then on, I had this inquisition that we must do something with really small things. So I went to China, and then I got introduced to these two professors who basically introduced me to the concept of really small miniaturized work. That's when I contacted Professor Scopone and I said, Prof, in 2014, you spoke about micro ECRS, but after that, you have not done anything about it. He said, I don't like miniaturized work. I find it easier to do a normal PCNL. I said, that's sad because you're the one who introduced this to the world. So he said, why don't you do something about it? First, I said, you need to standardize it. If you don't standardize it, how do people replicate it? So then, in last year, we presented this step-by-step procedure. I'm going to try and so this is basically what a micro perk set has. This is something which will come to you from the company. It's the same company which has been making this for the last 15 years. So it's amazing how they haven't changed anything except maybe for the guide wire. They made a better guide wire now. So this is a video that we published. I'm just going to play this video. We'll run through it so
Yeah.
that it gives you a very clear sense of what I'm talking right now.
Microendoscopic combined intrarenal surgery.
Are you able to hear, Chandra?
Yeah. Yeah.
As shown here, various sizes of
You can
percutaneous
increase the sound
access
if possible.
in general, the lower the morbidity and the faster the recovery.
Yes.
Micro-ECIRS is a combination of micropercutaneous nephrolithotomy and retrograde intrarenal surgery. Micropercutaneous nephrolithotomy is carried out with a 4.8 French all-seeing optical needle, and retrograde intrarenal surgery can be done with any flexible ureteroscope. The two most common positions we use are butt free supine with French split leg and Gauhar modified supine Valdivia positions. This video aims to provide a step-by-step illustration on how to perform micro-ECIRS. Pre-operative preparation is of utmost importance in surgery. First, the operating theater setup. Two surgeons operate simultaneously, hence twin video sector setup is shown here. Patients should be appropriately positioned for renal access. In this case, the patient is embarked flank-free supine with French split leg position. If the patient has a bulky hip or pendulous abdomen, it can be taped to the other side as shown here to maximize exposure and space for the puncture. Next, a preoperative ultrasound is performed to localize the renal stone and surrounding soft tissue and to ensure that there is no bowel interposed. Then, the operative field is cleaned and draped. These are the equipment necessary for retrograde access and for antegrade access. The initial step of the procedure is to perform rigid cystoscopy and to insert a guide wire up to the kidney. Next, the T10, a 10 French double lumen ureteric catheter, is inserted retrogradely over the guide wire. This is to assess the elasticity of the ureter and to facilitate a retrograde pyelogram if needed.
I'm just pausing here to tell the friends who are looking that I always do this because we did a little study, and when we don't have a pre-stented ureter, patients are usually given tamsulosin before if they can tolerate. I always assess elasticity with the stent French. If the stent French can go all the way to the kidney, in 95% of the cases, I've always managed to put an access sheet up.
Yes.
All cases, I managed to get a 7.5 French scope without any difficulty, without any trauma, not even a grade 1 injury happened.
Yes. Important point.
Ureteric access sheet is then inserted carefully with its position confirmed.
So if you heard the word suction ureteric access sheath, this is something which I, over a period of time, have understood and learned that it has a very, very big value, especially when you're doing very miniaturized PCNL, because you need that fluid that's coming inside to constantly be draining out. And what better way to then drain it through a suction port where it allows all the fluid to continuously be drained. And we know that suction brings down the pressures, which can go up to 70, 80 millimeters down to 20 to 30 millimeters. So I have moved completely to a suction ureteric access sheath.
Alternatively, any ureteric access sheet can be used, taking care to ensure that the scope and access sheet diameter allow for
Is
sufficient.
it available with Cook?
The flexible ureter scope.
This was actually, I tried two companies. This was a Coastline company, and now I've moved completely to the Cleopatra company.
We don't have in India.
Cleopatra is available. They are willing to come. I know Dr. Desai's team is already using them.
So that is on research base.
Inserted via the ureteric access sheet, and the stone is visualized. We then move on to the micro PCNL. This is how the all-seeing needle is assembled. The micro perc is a 4.8 French needle which is used directly for puncture. It is more than 15 centimeters long and can therefore be used in obese patients where skin to stone distance is long. As shown here, the fiber optic system with the camera head is a separate attachment on a supporting rod. This removes weight off the part of the instrument being held by the surgeon, making the operation more ergonomic. A transpapillary puncture is made with the all-seeing needle under fluoroscopic guidance, using the bull's-eye triangulation or biplanar technique, or under ultrasound guidance. With retrograde access, you can visualize the puncture directly, and the rest of the procedure can also be completed under endoscopic vision.
Again, I'm pausing here to tell you, when I see this inside over here, I'm actually with the micro perc. The important part is you're ready to go straight away. There is nothing further you need because all you need to do is pass the fiber optic scope through this, and you're ready to continue. No dilatation involved.
Wire is inserted.
This is for demonstration purposes.
It's luxury to see the needle where it is coming from and then start off.
Absolutely. And this is just for this video's demonstration where we showed that you can actually do dilatation, but you don't have to do it.
Yeah.
Super stiff jade hip wire, which is available in the kit, is especially useful if a single-step dilatation is required. The all-seeing needle is then assembled by passing the optical fiber through it and attaching to provide microendoscopic combined. All-seeing needle is then assembled by passing the optical fiber through it and attaching the provided adapters and connectors as shown earlier. The assembly of the needle is easy and takes less than a minute. No additional implant sheet is required. Here we demonstrate the 4.8 French puncture being upsized to 8 French if necessary with a single visual dilatation, hence minimizing the risk of over or under dilating the site.
But Chandra, if there is one thing in this kit which I wish was available outside is that guide wire they provide. The
Yeah.
super stiff guide wire they have is just fantastic. And we've had so many other forum discussions, right? And we always talk about the fact that this guide wire doesn't go inside very well. This particular make of the guide wire is so good with its angulation that happens. Once it's inside the system, it does not come out unless you really exert amount of force.
I
But when
feel
you,
I feel
yeah,
frustrated with Termo. It comes out. I
absolutely,
work
that's
hard, it comes out.
and no matter what angle wire you use, it doesn't stay. But and the beauty about this is, as soon as you pass an instrument inside, the wire straightens out, and you can take it out. And it has never broken in all my cases. So I think the company does refuse to give you the wire separately, but it's a beautiful wire to have.
Great.
Once integrate access is secured, the flexible ureteroscope can be visualized and guided with the all-seeing needle to perform caliceal inspection. By having the ureteroscope and micropuck needle in different areas of the kidney, both surgeons can simultaneously or alternately start laser.
Again, I'm pausing in between just to tell you, see the amount of space that both the surgeons have to work with. If you had a bigger implants sheath inside, or you're very scared that if I bring one instrument to the other instrument, it can cause damage.
Yeah, that's important point.
Stone fragmentation is done using a combination of dusting and popcorning as well as top dusting. As shown here, stone fragmentation can be done retrogradely while maintaining a good grip rate from the micro PCNL sheath to ensure clear vision and prevent the buildup of intrarenal pressure, hence reducing the risk of sepsis. Antegrade stone fragmentation can be done alternately or simultaneously while maintaining a good grip rate from the ureteroid access sheath. Having a hand pump such as the
You
tractor
can use
also
either
helps
ways, from
the
below
stone
or above.
fragment faster, as only
It depends.
If one is
Often we
working,
use
other acts as a channel for the water to go out. Something like that.
so both surgeons can use the same time. That's why the suction access sheath really drains very well.
Yeah.
So the PCNL sheath on top, the minute you put an instrument inside, is a closed channel.
Yes.
If you put the instrument from below, it's good to have the suction sheath because then the system is continuously draining.
Okay.
If you don't have a suction sheet, it works very well, but
But
simultaneously, if you want to work, it can
very
be a little bit
challenging.
challenging.
Yeah.
So what I have now actually done is on top, if I find that is a very big stone, not for a small stone,
Yeah. Yeah.
for the very big stones, I actually put a peel away sheet as a implants inside and use the micropuck through that.
Okay.
So there's continuous drainage from both ends now.
Yeah.
And the peel away sheet advantage is you can get them right from 8 French up to 12 French. So you decide whatever French you want.
offers
Yes.
good drainage antegrately and retrogradely. It can be used liberally without any complications due to pyelovenous or pyelolymphatic response. Suction tubing can also be connected to the uretary access
This
sheath.
flexible scope suction works well.
Yes, suction works very well. The key is to know how to position the suction sheet because this suction, when you connect to the sheath over here, a very practical point is it gets heavy. The sheet will tend to slip out. So you must take a slightly longer sheet when you want to use a suction action sheet.
Yeah.
So I use for men 45 centimeters and for women 35 centimeters.
Okay. Okay. I keep a person at the nearest to hold it.
Procedure
Yeah.
in one
58 centimeters.
when stone clearance is achieved, the access sheet is removed under direct vision without the need for a nephrostomy tube. There are several advantages of this procedure. Firstly, this is a miniaturized single-step visually guided puncture. The puncture is done under endoscopic guidance and the all-seeing needle increases the ease and accuracy of percutaneous access. This overcomes challenging.
Remember when I showed you Professor Desai's current urology opinion, where he said the biggest point about this is an all-seeing needle. So when we were doing this thing, presentation together, when I asked him, he said you have to use this all-seeing needle in a much better way than what is being advocated. So I said, what do you want us to do? So he said, I think if we can use this like a fascial dilator and go directly inside. I said, yeah, that's how I saw it being trained in China. So he said, wonderful, and we should try to develop that technique because this all-seeing needle is not to see inside. Yes, as soon as you go inside, put your fiber optic scope, it shows you everything. Why can't we make it even better where right from the skin, can I see all the way inside? And I'm going to show you a small video that can be done.
Anatomy in those with multiple intrarenal diversity. This is a single-step puncture without the need for dilatation, hence reducing bleeding, which is essential for patients on anticoagulation. This also removes the need for a nephrostomy, thus recovery is faster. While both the Batts length free supine and GMSV positions are ideal, French position allows treatment of patients with physical limitations for lithotomy, such as section deformities or obesity. Bidirectional lithotripsy minimizes operative time, and most patients can go home the same day or the next day. Low intrarenal pressure is maintained with good fluid drainage both passively and by active suctioning. This prevents sepsis and removes stone fragments for clear vision throughout. And lastly, the ergonomics of this operation are improved as both surgeons can remain seated comfortably throughout, and the micro PCNL camera head is assembled separately, thus reducing the weight of the parts of the instrument being held. This procedure is ergonomic for both surgeons and is economically viable with 100% stone-free rate and no significant complications.
So I was able to fulfill the criteria that I thought we should have with the procedure, which is small.
Yeah.
Now, why can we move this even further? So I spoke to my friend, good friend Takaki in Japan, and he was already doing this. I said, I want to do this even for micro ECRS. So he joined me in this. And this is to show you a wideband Doppler. You must have seen. So normal, when we do a Doppler, this is using the micropug, just a micropug in the Doppler. See how well the needle is visualized inside the system. When you do a micropug with the ultrasound, you will realize that the needle actually looks really, really good. And as you can see it coming in there, the tip is so well acoustic because it's got serrations on the tip. Those serrations make it very, very good acoustic.
Yeah.
Now, this needs learning, but if you can learn the wideband Doppler in a system which is moderately dilated, you can actually appreciate this arterial flow very well. And that allows you to guide you very well. So over here, you actually see what is happening as a micro ECRS using the wideband Doppler, which we did. And the flexible scope is introduced just like how we are. The papilla is identified. Now I'm looking at the kidney clearly. I do the same thing that I do here. And I confirm my puncture line in the same way that I did over here. That technique doesn't change. You have to hold the probe transversely. And if you observe that needle coming in, the white, if I just take it back one step, you see this flash of silver, that is the tract which is showing that coming in exactly into the kidney. And you can, inside view will be exactly like how we are used to seeing, where you'll see it coming smack in the center of the papilla. And then, of course, the rest of the procedure is the same. You want to do it single step, you want to dilate, you can do everything. This allows you to take away the need for fluoroscopy almost 100%. Only maybe when placing the access sheath from below, you need probably some fluoroscopy. That also, if you do urotoscopy, sometimes you don't need to place a fluoroscopy guided access sheath. You can place it yourself. And this is very useful in Japan. They're actually trying to do it on children, and they're really getting good results. So I'm grateful he taught me. I'm using it. I'm still in my infant stage when it comes to ultrasound and Doppler, etc. This is a bit complicated and difficult to learn, but I'm trying to improve myself day by day. But I thought this is a great option to have. Now over here, I wanted to show you when we're talking about the partial dilatation. I'm going to take off the sound over here. So over here, this is a real time where it's being done in prone, where a little bit of syringe is held to syringe. And now I'm starting from the skin, and we are going, not me, but the Professor Legion I learned it from. I couldn't get my video for this. And we are actually going step by step inside. When I was holding the ultrasound probe for him, it was very easy. And then hardly in a minute, this is real time, I haven't edited the video. In a minute, you're inside. What you can encounter may be some oozing or bleeding that can happen from the edge over here. Just flush it with a bit of water. So this is the tract which is just dilated, like fresh. You can see fat from here, which is just below. And then from the skin, I'm walking all the way through, and you can enter the kidney. It is doable, and if you do it, you'll suddenly realize that, oh, how come I didn't think about this before? And this is a very easy technique, and we named this technique the visual fascial assisted simultaneous dilatation technique. And the VFast technique is really fast. So, you keep thinking of how more can you improve. I just told you that, and this is now what we sometimes use. Professor Kemal actually introduced me to the concept of doing irrigation suction, and as well as the SMP, which is the super mini PCNL. And he told me, he said, if you're putting a micro plug from there, and let's just say you can't put a access sheet from below, Does that mean we can't do ECRS? I said, no, I think we can, Prof, but the pressure will go up. He said, why don't you try with these? Just use one of these peel away implants, put this inside, put your microplug through this. I said, will it go through? And it did, because it's 15 centimeter long. Is more than enough length to go through. So understanding the equipment and using it is very, very critical. Once we started doing that, we realized you can actually go from the smallest size to the biggest size, no matter what size. And that technique has been called the Matryoshka technique. We now use it very regularly. So I always start small. And anytime I want to make it bigger, it's just one dilator, and it goes up to any size you want to make it.
Yeah.
So that allowed me to do what you were saying just now, tailored management, where
Yeah.
I discuss in detail. So I spend time with the patient in my clinic when I have to talk to him about something a bit more advanced. I tell them, I show them the CT scan, I talk to them about the treatment choices, I tell them about our experience and all the other parameters, which are Hounsfield unit or heterogeneity. I give them realistic expectations about the outcome. We talk about how much money they have to plan the surgery for them. You have to meet the expectations of both the patient and the family today. And the decision is between you and the patient. And this takes time. So I tend to run dedicated clinics when I have to talk about stones. I give them an option to come back to see me, after my clinic hours, whenever I'm free to sit and talk to those patients. And with experience, what happens is, I mean, if you look at these stones, typically we would not want to do anything but a PCNL for them. Then I started doing different kinds of PCNL, and initially it was 24 French. Then I decided, let me try to become smaller. So I became 16. Then I went down to 14. Now I've gone to even smaller micro. When I put an access sheet, now I'm able to do even the bigger 2-3 centimeter stones without a problem. And the number of the track size has become smaller. The option to do a micro ECRS has become easier. And this is nothing much to talk about. 16 French, 8 French, and a 4.8 to cosmetically look at. Yeah, fantastic. We don't do anything for all of these tracks. Nobody puts a nephrostomy tube. And I actually changed my nephrostomy tube practice when I was glad when Harshvardhan introduced me to Starbucks group, where everybody was so confident of doing a tubeless PCN. And I said, okay, let me also try. And I only very recently I had the confidence to do this with the 16 French. But with the 4.8 and the 8 French, obviously I'm not putting any tube inside, but
Yeah.
there's no pain at all. When I finish the procedure, I just give them a little bit of local. We have even done this under a paravertebral block, and the 4.8 French actually works beautifully for those cases. You can't do an ECRS, but you can do a microperk under paravertebral block. And this is something which I'm observing in our studies and with our patients over a period of time, that the single stage stone free rate is going up even with micro ECRS.
Yeah.
The problem initially was we were not experienced, so we used to have a bit of dust inside. Now we are able to get rid of that with the suction. The average number of procedures to treat the bigger stones is coming down. I'm able to get them better in one surgery. My hospital stay definitely has improved for the patients. I used to keep them back initially, worried that something will go wrong, but now I don't. Most of the procedures, irrespective, go home within 1 to 1.5 days. Um, and the number of ancillary procedures, that means, the CT scans, bringing that for a second surgery, doing ESWL, sandwich therapy, that's almost obsolete now. And that's just because you gain experience as you move along. And this allowed another interesting concept to develop in my mind, which was actually proposed by Professor Anup, where Anup Patel said this concept of PSAP, which is, taking the patient, the stone, the pathophysiology and anatomy and all these skills. The idea of PSA, which is a patient's specific approach, was initially told by Professor Paley. He introduced the concept of even doing what we call as the pathophysiology, which is how the presentation is. And I thought to myself, we should develop it slightly more. And I spoke to Professor Valdivia and Nebrulesa, and we discussed it in detail, got all of them on board. And today, we honestly, I was very fortunate to have this publication, and we are really doing this now. We are doing this where we are using the ECRS. It can be micro or mini. Sometimes you combine the micro with the mini when you have a very complex stone. One puncture can be a big one, another puncture can be a small one, and we get away with almost all the stones with the single stage stone free, because ultimately that's what we want. And it was I was very lucky that I had this opportunity today to talk about this, and my paper, which all the things which I showed you, has actually got published.
Very.
And this was just today, so I was very fortunate to have that to share with you directly on the forum what we have spoken about in more detail. And then I think it's definitely doable We have shown it. We are doing it. Next will be the outcome results, but we were asked to present it, and this is what I was talking about, the visual fascial access. So what happened with that is I've now become confident to even do complex cases like these. And imagine earlier you would be thinking, I can't definitely do micro surgery for these, but I think you should do micro surgery because where is the space in this system? What kind of a system is this where you get this kind of anatomy? There is a metric stone with the whole system full over here. I don't have space. So, I'm working from one end. My surgeon with a micro PCR is doing another one here. Polycystic kidneys, and the numbers just go on and on. The key is experience. The key is understanding. It takes time, but I think it's definitely doable. Now, I'll say that earlier we used to talk about limitations for supine PCNL, right? And by
Yeah.
doing ECRS, all those disadvantages, whether accessing whether the space for going up to the upper pole, is it difficult to do in a complex kidney which moves a lot, injuries to the colon, liver, spleen, all these are overcome by ECRS. But
Yes.
definitely by doing micro ECRS, it's become easier, in fact, to do all these things.
Yes.
So I personally think that the biggest advantage of supine BCNL and miniatures access is ergonomics. I showed you those are so light. The weight of the thing is so two surgeons sitting down. My boss who works with me, he doesn't like to sit, but I keep telling him, at least for the video, sit down. But when he sat down one day, he said, yeah, it's actually much cooler because you're using a laser. That's the limitation, right? And if you're using a laser, it takes time if you want to do a good job. You
Yes.
can ramp up the energy, but it takes time. And if you don't have patience and time, then please don't do this surgery. Use a normal PCNL, break the stone and remove it. It's your choice. But this is just something that we thought we'll share.
Yeah.
And I think guidelines keep changing. At this point, we probably don't have, funnily, ECRS anywhere. I was hoping that it comes this year, but because of COVID, I think it's not here. But I'm sure in the guidelines ahead, we will see ECRS in EAU guidelines as well. So with that, I think I thank everybody. I take this opportunity to thank you, but I also thank all my mentors and people who have been influential in getting me here. Thank you once again to all of you viewers who logged in and to Chandra, especially you, for the opportunity to share my work.
Great. First of all, I congratulate for the paper you have written and published today. It is very well thought. To be honest, do the job with a small hole, that is going to be the future. You combined, concept was there, you have gone one step ahead, thought, can it be with the smallest track, the purpose is served. Now I will ask, usually at the end I will ask some questions,
Sure.
and so that the juniors get benefited. First question is, with this current concept, do you think that supracoastal puncture slowly, incidence of doing supracoastal punctures will decrease a lot?
Absolutely. I think it's we had to do one supracostal puncture because I put that patient in prone position, and I could not do an ECRS on below
In
because
supine position, I feel that if you are good in RIRS,
yes,
if you can go into upper calyx in the presence of the nephrostomy tract, come on, you can. In the presence of thulium fiber laser, I say that that's an maybe an end of the road for supracostal puncture. Honestly,
I
unless it's a
completely agree.
diverticular stone or not accessible to the even that supine PCNL will do. But from too high a kidney, we don't know. But the incidence of multiple tracts and supracostal tracts will definitely decrease in future because of combined surgery. You agree for that?
Absolutely, absolutely agree.
Second question, in the era of lasers, do you still think that the density of this stone, I'm not saying volume of the stone, things are moving from stone size to volume, but nothing has changed last 5 years regarding the density of the stone. From beginning I have a feeling that one who uses laser, the dense, even pneumatic, the density of the stone is slowly not influencing the factor much except ESWL.
So I can add to that point because you're already making the statement which is correct. But when I say that, there's a beautiful paper which was released on the heterogeneity index of a stone,
Yeah.
which actually moves the cursor across different points of the
Yes,
stone, and you
yes.
realize the Hounsfield changes.
Yes, yes.
So what I started doing, and I will be publishing that, it'll come out. Hopefully, it gets accepted. So we moved the heterogeneity index, we measure of the stone and realize that it is higher the heterogeneity. That means the stone is not hard everywhere.
Yes.
And when you flip this into a bone window, you realize the stone which looked very hard actually doesn't look that radiodense anymore.
Yes.
And if I only a staghorn, I'm wary about using a laser.
Yeah.
In any other stone, I have never had the need to change. And we were the first people in the world to try the cyberwand. We were the first people in the world to get an opportunity to try the shock pulse. And I honestly think they are great devices to have, but you don't really need them
Yes.
now if you understand what stone you're dealing with.
Yes. This is the third one. The fourth question: if you are using ECIRS, micro ECIRS, if your puncture is exactly in the center of the papilla without any bleeding, and if you think that it takes long time to remove the stone, is it not safe to dilate up to 15 French? That
Yes,
means
yes.
you observed with flexible scope, you have punctured, center of the papilla it has come, non-dilated meaty kidney. Even then, you can dilate up to 15 French without much bleeding, so that you can change your versions like micro, ultra mini,
Absolutely,
and
Chandra.
definitely up to mini you can finish large stones.
You must be very flexible when you do flexible, stone management today.
Yes,
The what you said is very true. Sometimes we go in, no matter how many CT scans you look at, whatever is your knowledge, when
yes,
you go there,
yes,
that stone will tell you what it wants and how it wants to behave.
yes,
And when we put the micro CRS, sometimes it's so hard, it
yes,
frustrates you.
yes,
What I do that time is I don't waste time. In 5 minutes, I showed you those peel away dilators. I put that inside. I don't want to open a new camera system. I
yes.
already have one there. So I just put back a guide wire, one dilatation, put the peel away sheet. I sometimes go 12 or sometimes do go 15 depending upon the volume of stone.
And finish the
And I
job.
use the same micro perk system through that. That's all.
Yes, so that your space to work increases, your fragment movement increases, pressure decreases.
I want to now not dust, I want to fragment because I want the
Yeah,
fragments to wash out.
yeah, fragment to wash out. So there is no definitive criteria that I do only dust, I do only fragments.
No, no.
It depends on the case.
Why should you be restricted when you have a
Yeah.
versatile tool?
Yes. If you are using flexible scope to help the nephroscope person, why you want it to dust? You make three
Exactly.
pieces and give it to him. He will remove them, and
Absolutely.
it is very time effective. I mean,
And
takes
and that
time
point
less.
is very, very valid what you said. If I have somebody from below, why should
Yeah.
I waste my time dusting? Just break it. He can remove it from below. In
Yeah.
15 minutes, a 1.5 centimeter stone will be finished.
Yes. So it should see there is nothing like dusting only to be done. Or I used to say I am duster. It is not like that. Things have changed a lot in last 1 year. Lasers have changed. Now my sixth question: lot of people are saying that 50 micron size fiber is coming in thulium fiber laser. It has not come. Theory. It's only theory. Even big people are saying that oh, it will change. Even 100 has not come in India.
Yeah.
But if it comes 50, will there be any? Is there any word lesser than micro in a English literature?
I don't know. I think
See,
somebody will
the
come up.
flexible scope and nephroscope future will change with improvement of optics and lesser laser fiber. What is your imagination when your son is practicing like you?
Okay.
If 50
I
micron
think
fiber comes,
let me tell you the limitation of all instruments is
yeah,
not the tip of the instrument. The tips of the instruments can be as small as they want. Even before, the tip was 7.5 inch.
yeah,
The companies have a problem in the shaft of the instrument.
yeah,
They are not able to make the shaft smaller than this because the channel becomes smaller, number one.
yeah,
And the instrument's ability to bend is definitely more fragile.
okay,
So when the fragility of the instrument goes up, so it does not matter if you have a 50 micron, 100 micron fiber, because you can't go smaller than we are already there at the moment unless there are
yes,
new materials that develop. But if the fiber size becomes smaller, I personally think a 100 micron fiber will be fantastic to have for the lower pole.
yes, yes,
But that's about all. I do not need a 50 micron fiber.
yes,
And when I use very, very high, as you also must be using, when you use very high energy, the vibration, I don't want a very thin fiber. Honestly, it's more difficult to do. If I want it to be slightly manageable, so I want the fiber at about 100, 150, 200. I'm quite comfortable handling the fiber inside.
In the seventh question, I ask you to put you in trouble. Six French flexible scope, six French nephroscope with 50 micron thulium fiber laser. One day can handle stagger volume of more than 2000 square cube mm. Is it
Maybe
possible?
with multiple
Six
punctures,
French
yeah.
flexible scope, six French flexible scope disposable, one time maybe Indian 10,000 rupees, and a good sturdy six French. You are saying it's not possible, but six French nephroscope with 50 micron laser fiber, thulium fiber laser 60 watts. Can we manage high volume that is more than 2000 cubic mm? May not be a staghorn, but a large volume stone, hard stone. Can you imagine like that, Maltrame? That's what your topic is today, actually.
I'm so we are doing that in our studies, and we have done a lot of partial stack on stones
Yeah, that means
with the
it's
micro
possible.
ECIRS.
That means it's
And
possible.
it is possible, it is
Possible.
doable, and you don't have to, I don't worry about the concept of pressure or sepsis anymore.
Yeah. So if you don't worry about the concept of sepsis, I say I don't worry about the bleeding to the death also. Do you think that angioembolization can occur if any amount of the this thing, but bleeding to death will be stopped forever? Mortality because of the PCNL should not be there down the line.
Definitely, definitely. So I
That's
think,
what my wish,
yeah,
that if a large stone, because large stone only people are doing larger dilatations, inadvertently sometimes injuring the major vessel, and before angioembolization, if patient goes into hypotension, it's a disaster.
yeah.
While transport only, that's thing anywhere rare. See, a lot of seniors says that it never happened to them, but a lot of juniors who have faced that will never forget that.
I always ask some of the seniors if they have the mood to answer. I tell them, when you were a junior, didn't it happen to you?
Yeah, it will happen. You can't say that. A 30 years old senior should not talk about PCNL complications at all. I
You know,
say
but
3 year
Chandra,
old
but that's the
surgeon.
thing. The professors in our country, they are so good. They've done thousands of cases. I
Yeah.
you expect them to be champions, and we have to respect the fact that they know what they're doing. But
Yes.
I totally agree with you that miniaturization reduces the morbidity of bleeding. It
Undoubtedly.
does not reduce the incidence of bleeding because you didn't do the puncture properly.
Yes.
It reduces the morbidity of the procedure leading to a bleeding because there's not much talking, number one. The chance of you causing a major vessel injury is lesser. And by ECRS, you're reducing the number of punctures. So theoretically, you're reducing the chance of
Yeah.
causing injury.
So my eighth question: ectopic and mal-rotated kidneys. Ectopic and mal-rotated kidneys. These things are changing a lot. Flexible ureteroscopy is becoming first line of choice. Go in and see, then only adopt complex puncture or complex combination of puncture with laparoscopy. You also have presented many times, even in my forum you have presented. You have enough treated the malrotated and ectopic kidneys. What is your opinion?
Yes, I totally agree. In fact, my first choice is usually RIRS for the ectopic malrotated kidneys.
Yes.
But my just a practical experience in my hand is if I stent them, I find it easier to do RIRS.
Very, very good. Very, very valid point. I also feel.
Yeah.
Just do not hesitate to stand.
Yeah.
Oh, it's luxury. Moving inside also. The PCS is compact, and usually it is complex. One calyx goes down, one calyx goes back,
Yes.
something like that. You need to have some space in the ureter to move the flexible scope.
So, now it strikes me when you say, so I think that point which you said, 6 French diameter scope, if I have it in an ectopic or a malrotated kidney, it will be fantastic.
Fantastic. Same way what you said is 100 micron. If you have deep inferior calyx can be powdered, and if suction is there, spot clearance you can give.
Very true.
So that is this thing. And in children, now I do a bit more practice of pediatric. Today also I have shared pediatric PCNL also. This micro ECIRS is going to stay for a long time. Is the gut feeling I am having today? Comment on that.
No, it's in fact it is the reason why he spoke about it in 2014 was mainly for children
Yeah,
and ectopic kidneys. So that's when he said, I don't know about the adults, but the children, I think it's a revolutionary tool.
yeah,
Again, what happened is people did not use micro ECRS in children because they're always scared that the ureter or the urethra will get damaged.
yeah.
So people started doing micro PCNL Until then, suddenly Professor Janak Desai and other people introduced Ultra Mini and Super Mini. So they said, oh, that it is much better to have no need to put a sheath from below, put your scope from below directly, but
Yeah.
at least you have outflow from top, so the pressure is low.
So my
Once you have the confidence that putting an access sheath in a child is not the problem,
yeah.
but to know how to do it is what you need to have experience.
Yes, 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 yes.
Then I think micro ECRS is a game changer.
Very, very important. The last question: what are the instruments, uh, the company instruments? This is a private question, but we wanted to know what are the flexible scopes you like and study, and honest answer I want, because you might have used everyone. There's no conflicts of interest, honestly, no conflicts of interest. It's an exchange of the opinion, that's all. The which size nephroscope you commonly use and enjoy, and which flexible ureteroscope you commonly use and enjoy.
I was I mean, like you said, I mean, there's I've had the fortunate opportunity of using many of these disposable
Yes, yes,
instruments.
yes.
I was the first person, I think, in Asia to use the LithoView,
Yeah,
and I loved it. I liked it so much that for the rest of my 500-600 cases, I did not use any other instrument after that.
yeah.
And not many people know that the LithoView is actually designed to go into the lower pole, but they
Okay.
did not want to advertise it because they said people will only use it for the lower pole. So they introduced the concept of disposable scopes, and we really followed it. I really liked the LithoView, except the vision was a bit inferior
Yeah.
because it was not bright. So the Pusan company came in at the same time. I was very disappointed with them, and I told them I will not use their scope.
Yeah.
But they came out with a new 7.5
Yes.
French scope, which
Yes.
is
That
fantastic.
did not come to us, unfortunately.
But you already have the Indo-Invasive
Yeah.
7.5
Otherwise, you
French.
have
So
7 point.
7.5 French has beautiful vision.
Yeah, beautiful.
I think the at this point the scope, which is from the Axis scope, which is basically from Donier, or you have the Innovex scope. All these are made from the same company. They just sold in different brands. This company sells the scopes. I think they're about 8 French. They have beautiful vision. They have the best vision in the market. When it,
The nephroscope you are talking about?
no, no, flexible rotoscopes.
Ureteroscope. Okay, okay.
And then comes the Pusan scope because it is very thin and good. Similarly, the Indovasive scope. Now, flexible scopes, I think these are the 4 scopes I personally like now. In the upper tract, my go-to is usually the Karl Storz mini BCNL set.
I agree that.
I have not had the opportunity to use the other companies,
Yeah.
but ever since I started doing micro and PCNL, what I am starting to prefer to use the Cleopatra sheet, the suction, the renal sheet as well,
Yeah.
and also one of the companies which has a peel away sheet, which is sold even by Cook.
Yeah.
So they have beautiful PCNL sheets. I like to use those sheets.
Fantastic. That's the answer I wanted. I prefer Indovasive and Starch company too if I have to choose. But otherwise, routinely we use P7, and the I don't even nephroscope I did not use other ones, because from beginning we use Starch, so we are adapted. Some people say there are Wolf scope is also Dredson is very good nephroscope, but smaller size is not available. Ultra Miniperk access,
Yeah, it's not there.
because our talk is today micro ECIRS, I am bringing this point. The Pusen as well as Indevasive 7.5 and Starge 7.5 to 9.5 French, the with 11 French access sheath is commonly used. So with this, Vineet, we have completed 1 hour. 210 people have seen the program, and
Oh,
hope by tomorrow it will reach 1,000. These are all very important talks. The best part I have seen is that you presented video and scientific background, and your paper also accepted. I am seeing a lot of future with you. Hope that God gives great energy so that the younger generations will remember your publications and your aggressive communication. Great, I
thank you.
appreciate, and I will be calling you again and again. This is a continuous process. In another perspective, I will take your help. So thank you very much being with us today. Thank you.
Thank you, everybody. And please stay safe where you are,